in order. I would say let's make a pledge to the allegiance, but I don't know if we can get out of our chairs. Let's please rise and Vaughn, please lead us in the pledge.
Thank you, Mr. Mayor. Please join me in saluting the greatest flag in the world. I pledge allegiance
to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
That's right. Call the roll for the Health Board.
Yes, Ms. O'Neill.
Councilwoman Ratty. Here. Councilwoman Zachary. Here. Commissioner Jung.
Present.
Dr. Furman.
here.
Dr. Hess.
Here.
Dr. Humphries.
Here.
And Chairman Smith.
Here.
Mr. Chair, Dr. Long.
Thank you.
All right. For Washoe County.
David Humphrey, Chairman, absent. Lonnie Weber, Vice Chair.
Here.
Commissioner Jung.
Present.
Commissioner Hartung.
Here.
Commissioner Berkeley. Here. We have a quorum.
Okay. City of Reno.
Shivi.
Here.
Breckus.
Here.
Zadra.
Here.
Delgado. Dorch. Absent. Jardin.
Here.
Cashel.
Here. City of Sparks.
Mayor Martini,
Here.
council members Ratty, Lawson, Smith, Kerrigan, Schmidt, city manager Perry,
Here.
and city attorney Chet Adams.
Here.
We have a quorum.
Okay. Go to approval of the, no, excuse me, public comment. Public comment, Dennis Jacobson.
Good morning, Commissioners and Council, managers, mayors. For the record, Dennis Jacobson. I represent the Reno firefighters. Just a few comments very briefly. I'm in my 28th year of providing various types of public service, EMS and emergency services to our community, majority of which have been pre-hospital through the fire services. But I'll date myself and say that I also worked with Washoe Med in their ER and trauma centers back in the day. Through that time, I've seen a lot of changes, as we can all imagine, and many of which we're aware of. Starting out with our three competing ambulance companies back in the late 70s and the early 80s, which had a culmination basically with a paramedic strike that happened back in that era, mid-80s, and your predecessors in the health department creating the Regional Emergency Medical Services Authority to govern over this critical phase of our service delivery to the public and assure that this wouldn't happen again. Obviously, in the last 26 years, we've seen a lot of changes, a lot of growth with the authority, a lot of growth with the fire departments, and it brings us to what we are discussing today. After numerous studies and recommendations from experts over the years on how we can better deliver our service, we now have another one to consider in front of us, which is the Tridata Company. As a primary stakeholder, my association was involved at various levels of workshops and meetings, as I think were many of you. With the development of this report, I can speak personally that I found Dr. Cohen and his team very knowledgeable, not only with the needs of this community through their research, but also with the trends and the laws governing us around the country. And I believe we have a very good work product again to consider. Interestingly enough, that many of the recommendations within this work product and this report parallel those that we have seen throughout the last 26 years in reports, which unfortunately, for whatever reason, by many of your predecessors, currently exist on a shelf collecting dust. A lot of these recommendations were not enacted. To switch gears a little bit, those of us who were at the Chamber's Dimensions 2013 conference last week witnessed some very interesting speakers and some very interesting concepts, not the least of which was our managers discussing the opportunities that we have as a community to work together, not only at our level, but more importantly at your level, as the elected bodies levels. But unfortunately, it was just concept at this point. I mean, we've done some steps in the past with our flood control and with RTC, but we can take it further, and you have the opportunity today, I believe, to put action to our managers' concepts of cooperation. We have a number of issues at hand today. We have many of issues that you're going to hear throughout the report. But ultimately, the responsibility falls on the shoulders, as it should, of the elected officials, because that's who the public has placed their trust in. And I will try to maybe ease the burden that you have faced just a little bit by giving a tiny bit of advice from our perspective. These are very, very difficult decisions. They affect public safety. We take them very seriously. But in your consideration, don't worry or don't be concerned about, I believe, the fire departments. We are very, very adaptive. We'll make do. Okay, thank you.
Thank you very much. Having no other public comments cards, I'll close the public comment section. This is a joint meeting of the Washoe County Health Department, Washoe County Commissioners, Washoe County, or excuse me, City of Sparks and City of Reno, right?
I think so.
All right. Well, we got that down. I wasn't sure I got them all. All right. Presentation, discussion, potential direction to staff regarding the August 2012 Tri-Data Emergency Medical Systems Analysis. Who's giving the report?
Mayor, members of the City Councils and the County Commissioners, Sean Carey from the City of Sparks. It's my pleasure today to introduce Dr. Harold Cohen to you. Dr. Cohen is the author of the Tri-Data Report, which was pushed through by the Washoe County Commissioners to provide guidance to us in working on our entire emergency medical system. I wanted to thank Dr. Joe Iser and Andrew Klinger and Katie Simon for their leadership in working on this issue since the month of December. And with that, for those of you who are new, the reports you received today are intended to provide you a good scan of what has occurred over the last 19 to 20 years, depending on your time frame. They also bring you forward to modern times and look at the opportunities to use technology and to use the very best in patient care in what can be a modernized integrated system where all of the current providers and those that we may seek can be best accommodated. And with that brief introduction, I'd like to bring forward Dr. Cohen for his presentation.
Thank you, Manager Carey. Good morning, mayors and elected officials, ladies and gentlemen. First, I want to start off by again thanking you, each of you and the collective you, for allowing Tri-Data to continue to provide service for you when it comes to the future of the emergency medical services system. Lynette, can we get the video, please? Thank you. Thank you very much for your assistance this morning. Many of you here have heard a lot of this, whether it be in a public forum or privately in meetings separately. However, there are some of you who this is the first time you will be hearing this today, and I'll go through that. I'm going to move through this rather quickly because a lot of it revolves around not incidentals, but some very basic concepts that we believe are important for EMS in Washoe County. We're just going to talk about a few things this morning. What did we do? What are the critical issues? And what are the possibilities and where to go with that? And I think one of the good news factors here is while there are critical issues, there are a lot of places to grow. And we'll find that if we choose to go in that direction, we could really make a positive gain from this throughout. Basically, we saw a couple of major challenges. They're there. We don't have to go through them piece by piece, but they can be looked at this way. First is there needs to be a system. What's happening now is a lot of subsystems, but no real EMS system at the county level. It's just a number of agencies. There's no clear lead agency, in many cases, between the individual fire department or rescue squad and the state. That's it. The second issue deals with information management. There is no centralized, transparent data system, starting from dispatch, going all the way through to actually rehabilitation, which includes our hospitals in this. Now, one of the things to think about when we go through this is each entity, whether it's the county or individuals within or individual governments, are concerned about the oversight of EMS and the provision of that to their citizens. Regardless of what structure is taken in the future, the centralized acquisition and use and availability of data is the control mechanism, because it will allow each governing body to look and say, what can we do with the system as a whole? And it can be immediately available. And that's not done today, happening today. When that's done, it almost doesn't matter who is in charge, because everybody will be. Everybody will have the oversight they need, whether it be county or whether it be local government or whichever lead agency. And there does need to be some work with the EMS franchise agreement. We'll talk a little bit more about that, but that can happen. Currently, you're using a public utility model EMS system. And basically that means the government has given an agency the oversight to do that. Back in the 80s and 90s, about 7% of emergency medical services in the country were done that way. It hasn't panned out to be what everybody thought it was going to be when it came to saving money. And now it's down to a little less than 2% of EMS systems across the country use that. And obviously one thing we can't change is what about the diversity of the geography of this county? And we have to do it, we have to live with it, and we have to thrive because of it. A couple of things to consider, and that is there's not much choice in the matter here. And maybe it's just intervention of some type, but the economic situation has compelled all of our systems, whether it's county or local, we got to do something different because economically we can't support what we're doing right now. And that has to also be balanced with having EMS and providing EMS are two very different things. Obviously, to make these changes, whichever changes that you all decide are the wise things to do, it takes legislation and a collaborative effort. And that will be the future of the stakeholders here. Collaborative effort and the understanding by others that failure to be part of that collaborative effort will really be a failure to, an inability to participate in the system. Being the group that throws the X card or the group that just won't accept anything will obviously not be acceptable in the future. And I'm sure that whatever governance structure that you make, that you're going to be very clear about that. One of the things that we really need to do here in Washoe County and in the cities, we believe, is keep our eye on the ball. Look at adaptive issues, the big picture. Sometimes in EMS, we get drowned in the technical issues. Who buys the equipment, who runs things, who's in charge at the incident, those situations. And believe me, you're not there yet. If you do things right at step one, the subsystems will work out. They will work out. One of the biggest things which the county and the cities have taken action on, and that is EMS dispatch, which we call the Atlas and the Axis for your system. First, it has to get the right equipment to the right people. It has to be able to work with different subsystems and be able to give them the same quality of service, whether it's the Reno area, Sparks area, fire department, REMSA situation, or you're at the more of a separate system with North Lake Tahoe or Gerlach. It has to work for all of them because all three of the systems now do contribute to making things work out well. And even in the future, they'll be fine there if the top can be taken care of. One of the first things that can happen, and it's already happening with the Sheriff's Department stepping in and taking a major role in the county with dispatch, and other agencies cooperating with that effort, is you're starting to get there. The one technical thing that we really need, and that is a universal incident number, so everybody can bring up an incident and know, what did the first responders from Sparks do? What did the EMS providers from REMSA do? How did they contribute to this patient's care? This is the biggest problem with the non-system that we are here. The data has to be here in real time. There's no reason why the oversight, the communications agencies, whether it's the Sheriff's Department, whether it's the City of Sparks, by the use of technology, cannot look up at a board and see where each piece of equipment is. And that's the easiest way to assure that the closest available unit responds to your citizens in an emergency. Folks, without that, we're not getting it. Without that, there is delay, and everybody can know what's going on. There's no reason that you can't. Technology can provide those answers, and no matter who is the oversight, whether it's a county agency, whether it's the District Board of Health, the political entities of the county, and the cities, by having oversight of that information and that availability, will have the oversight and control they need, regardless of who the day-to-day managers are of the system. That's the important piece that we're looking at here. We are having trouble analyzing the whole system. The first responders are very highly trained from the fire services. The agency leaders, we're happy to see, have started to take the ball and run with it, working together with each other. But I think the one thing that's the most important part of this is that the concept of first response and EMS care and transportation, whether it's done by the same group or whether it's done by separate agencies, everybody needs to understand you both need each other. And the biggest thing that can happen right now to move forward is for agencies to stop saying, we can do without you, and the response be, we can do without you, and that's got to get off the table. Because if it doesn't, we'll be right back here. I don't know, with me, you might have another consultant to be back here in a couple of years and tell you the same thing. I think you're at a time where those agencies are willing to do that right now. The biggest thing that we have to understand and really celebrate is it appears that excellent care is being provided. Patients are getting good treatment. There is good medical direction. So that should bring a collective sigh of relief to say, I don't have to walk out of here today with a new EMS system. It also leads to the impetus that now is the time to make those changes that are necessary. There are questions surrounding transparency and the sharing of non-proprietary data. Most data is not proprietary. There are some that is, and it's explained well in our report. Everything costs the taxpayers money. To say one organization is and one organization isn't is just inaccurate. You can couch it and say, well, it doesn't cost, it's not part of the tax base. Well, that might be true. But every time a first responder goes out into the field, we're talking about increased number, we're talking about just the basic costs, even if they would be there anyway. But we're also talking about the greater chances of injury, the greater chances of violence occurring. It affects workers' compensation and things like that. So there's cost everywhere. That's not all bad, though. It might be good cost. It might be good investment. But let's just understand that we're all everybody's part of the system, and if your leadership can get people to do that, I think you're well ahead of the game. There's also an excellent training program that's here, an excellent academy that will reach and has national accreditation. This is becoming more important because for those areas that use a national-based certification, you've got to graduate from an accredited paramedic school. So you have one. It's time that everybody can take advantage of it at this point. The contract right now needs work. It worked for the time it was needed to work, understanding the history of where this came from. But folks, it's time to revise that. It's time that the oversight agency needs to have true oversight. It cannot be unamendable. The only answer going to a judicial tribunal to make changes, discussing how rates will be done by binding arbitration is just archaic, where dispute resolution can come from within the leadership organization, and things like mediation. And as an ADR professional, that's a very sensitive issue with me, and I've seen a lot of success with it, and with good leadership, I think it's there. And I also believe that REMSA and RASI are ready to look into the future here for that. This is a high finance area. I mean, we don't have the exact figures because we couldn't get the data, but we think it's over $17.5 million a year changes hands because of EMS. Maybe a drop in the bucket to the whole healthcare industry, and it doesn't also measure the amount that comes into our healthcare providers when people are transported to their facilities. This is a big industry, and we have to respect it as that and understand that is underlying. How many responses? We really didn't know because the agency who was keeping that didn't have the data. We've just come up with a little more research and found that REMSA has over 52,000 emergency responses a year. Considerable. Considerable. Along with first response, we believe by 2015 you will surpass the 100,000 mark, making this county one of the busier counties in the country when it comes to the provision of emergency medical services here. So, you know, no matter what we do, no matter what advice we give, it's coming. And I don't really think anybody can or wants to stop it. So what did we conclude? You're being provided good care. You're being provided good care. The agencies that are providing that care, whether it be the first responders or whether it be the 3 authorized ambulance agencies, are doing fine. And your oversight model that you pick can keep that just the way it is, and you'll still continue to provide good care. The District Board of Health is more than capable of becoming the overseers, and I'm sure there's a county agency who can do that if the investment wants to be made. So you have the ammunition, you have the tools, and you have the talent, and that's really important for us. The biggest thing to remember is now's the time to get system issues, governance, communications, dispatch, and information management. That needs to be done first before any decision of who, what, when, where, and how. That'll come. That'll come. If you do step 1 right, it won't be easy, but it will be doable, and I think everybody is willing to do that. I've seen that the management of the fire services, I've seen the several labor organizations that we've worked with, also the EMS providers, and the oversight agencies, the government, the District Board of Health. I think everybody's just ready to do something to make things better for the future. Here. You're starting to do what I have right there on this slide. It's already started. The Sheriff's Department has taken their part of it, and whether we're in agreement or not with the vendor and the government organization, at least it's being talked about candidly. And you know, we're all human beings. We have to get over that. What candid means, it's not exactly what we may think or as easy as we want, but it's happening. So I think just the leadership that the political entities have shown and saying that we will take the system further is already started to make good on that. There's a number of ways that we can design the system, and I'm sure they will be much talked about in the near future. Regardless of who it is, an oversight agency needs to be here. There will be cost to it, but these can be mitigated costs throughout area. We can phase in positions, and some organizations may be able to provide some of the services needed to help mitigate taxpayer cost in these tougher times. That's all discussable. 911 consolidation, it's all got to be together, whether it's physically together or whether it is electronically together. That matters less. What does matter is everybody can see what's going on in every place, and that the oversight agencies are able to do that. They can look upon the picture and look at the picture as a whole and be able to dissect that, and that is what I believe is the political and administrative oversight that's necessary. We're talking about information systems. It's going to be one of the tough ones, folks. I think the hospitals can give you a lot of assistance with that because they have, in the past few years, also been with this challenge. The technology is there to do it. That's the way we can do that. Also, jurisdictional boundaries need to disappear. We may care about who comes to see us when we're well. Most citizens do not when they're sick. They're looking to see somebody who the government and its oversight agencies are well-trained, well-prepared, and get there quickly, and can do that. Also, REMSA and RASI have gotten access to funds, one of the 4 EMS systems in the country, I do have to mention, that is looking at expanding community care. As we said last time, and I firmly believe, it's time at the beginning to integrate the first responders into this right away. So the first responders can do the care in the community that they know how to do, and the paramedics can do the care that they are trained and licensed to do, and the right people are doing the right job, and our citizens are being served. We talked about this. I'm going to buzz through this pretty quickly. And that each part of the system is exactly that. It's a component from 911 all the way through patient rehabilitation. If we can walk out in the early part of these discussions and really say, even gritting our teeth at times, that the posturing between everybody, we have to just agree that that has to stop. At least the public posturing. Privately, we'll never get rid of it, and it's good to discuss differences in the right forum. But I think everybody's looking for the system to go forward, and that's what really needs to happen, and your leadership is what's going to do that. And we do know sometimes leadership isn't a very pretty sight, and that may be part of this a little bit. I don't think it has to be the whole thing, but I do think that there needs to be, it has to be there and available if necessary to do. But I do have to say you're off to a good start, folks. And I'll just keep it, I hope I didn't go too long with this. And Mr. Mayor, if I'll take your direction on answering questions.
Okay. Anybody got any questions? Yes.
Dr. Cohen.
There's a mic.
Dr. Cohen, thank you. Thank you for the report. You gave a figure of, I think it was 55,000 first response trips by REMSA. Is that correct?
55,000 ambulance calls. They're it's going to be about the same first response, because in this system, when there's a first responder going to a medical emergency, an ambulance is also going.
Okay, well, I don't understand that figure, because I know that I think our figures dispute that, where we're first responder or City of Reno is first responder thousands of times, and then REMSA shows up after the fact.
I was not purporting who got there first. I was just saying the total number of responses in REMSA's territory, which also includes the new combined territory, have added up. Who got there first? The fire department usually gets there first. And
that's fine. I thought I saw it say that they were first responders on 55,000 calls.
First response, it didn't mean first there.
Okay.
Whoever gets there first is the primary first responder.
Sure.
But no, that's, I'm sorry if that was
That's the way I took it. That's why I was
unclear.
trying to clarify it.
Okay. I hope I clarified it for you.
I don't know that you did.
We're about, depending on whose report you look at, about 60 to 75% of the time, the fire service first responders get there first. And that's the way, that's okay. That's the way the system is engineered.
It's okay. I would just like to ask our chief and Chief Hernandez how many first response calls we get.
Good to see you, sir. Yeah. For the record, Mike Hernandez, Reno Fire Chief. For the last year, council member, we responded to just over 30,000 EMS calls for service.
Okay.
Of those, just over 80%, 30,000 calls for service. Of those, about 80% were EMS-based calls. We have an industry, since we started tracking it, we have a response time of just under 6 minutes within the core of the city. So from the time of dispatch to the time that we actually put hands on the patient, that's right at about 6 minutes, just under 6 minutes, 5 minutes and 30 seconds, something like that. So
thank you, Chief.
Our first response call volume is about 30,000 calls.
Okay.
Councilman Smith, Andy Flock, Sparks Fire Chief, for the record. We ran about 7,300 calls for service last year.
Okay.
In regards to EMS.
Okay. Thank you. Thank you, Dr. Cohen.
Yes, Doctor.
Thank you, Councilman.
Dr. Cohen, I take it that this does not include the non-emergency transfers.
Yes, that's correct. There were, I think, about 8,000, and we really didn't measure that because that's really medical transportation. While it's part of the EMS system, it's direct between whoever the providers are and the people calling or the medical facilities calling. So there was about another 8,000, maybe a little more.
But it affects costs.
It does. It does.
Yes.
I have a question.
Yes, go ahead.
Thank you, Mr. Mayor. Dr. Cohen, I just have a fast question for you. In one of the reports that was put out, it said that in Washoe County, fire as first responders are costly and make little clinical difference in patient outcome. That was given to the District Board of Health by Fitch in August 2012. If we were to take first responders, fire completely out of the picture, in your opinion, would we see a difference in outcome?
If you look at the reports where that came from, that information is relied upon about a 12-year-old study out of Toronto, the city of Toronto, and only focused on patients in cardiopulmonary arrest. So people who are critically ill as it is, and most of them do not survive those anyway. But what we're also looking at, and which has not been measured greatly, but I can also tell you that Toronto did the same thing when it came to trouble breathing and found that their combination system actually decreased mortality by a couple % overall. But we don't have a lot of information yet when it comes to that. When it comes to just the patient without a pulse, that's there. But there's a lot of other things that haven't been considered. As first responder agencies, we're also responsible for the care to our citizens. Our citizens expect rapid, quick response and expect that when is the emergency over? When a trained provider gets there. And if you've ever been either served by the EMS system or know somebody who has, those first few minutes seem like forever. And if people are judging, are they being cared for by their EMS system, regardless, they expect service promptly because that can end the emergency. Getting emergency care started. How about things like workers' comp issues? When you have, in cases, 4 or 5 people there instead of 2, carrying equipment, moving people, etc., that's healthy for your providers, whether they're fire or EMS. It starts to lower the workers' compensation costs. It starts to lower the pension costs because fewer people pension out on back injuries because of the repetitive lifting, especially when there's only 2 people carrying the same person and the equipment that first response allows 5 to do. So really, you can't look at one emergency and one group of people and say it's worthless or it's not worthless. As I said in the beginning, our feeling Tri-Data is every part of the system needs every part of the system. Also, with the use of medical priority dispatch, we can hone in on exactly when first response is definitely needed. Those what we call the D or E level calls, those are the ones where we need to have first response. The other calls where local departments or cities have chosen to make a presence at every single medical emergency, let me be frank with you. It's nothing to argue about anymore. If that's what those cities want to do, that's what those cities should have the privilege of doing. They have to do the minimum. Everybody has to do the minimum standards. But if they want to do a little bit more, I think we have to yield to those political bodies and to those fire chiefs and rescue chiefs to say what's the right thing to do. I don't understand the argument.
One follow-up question, Mr. Mayor. And as you're aware, Dr. Cohen, we have, yes, thank you. We have a fair amount of suburban and rural areas. That's the characteristic of our region. Would there be a benefit because the response time is decreased the farther you get from the core by REMSA? Would there be a benefit for those first responders to have ALS?
Commissioner, I wish I knew the answer to that. And I would like to be able that either me or somebody stands before you in the next year to 18 months and give you an evidence-based answer to that. We don't have the data. What we have seen across the country is when this first all started, we thought training everybody to this level would make things better. So let's make everybody a paramedic, et cetera. Well, what we have found is the systems that have the lowest resuscitation rate are the ones where everybody's a paramedic, not just select people. And the reason being is just like a surgical skill, doing a cardiac cath or sewing somebody's wound up, the more times you do it, the better you get and the fewer side effects and untoward effects that you have. Right now, I think the most important thing while you're gathering extra data, and it won't take that long if you do it, is let's make sure everybody is already performing to the level that their license and certification allows them. Are the basic and advanced or intermediate EMTs that you have in the fire service now, are they doing everything they can do? By that, by the time you get some data, there may be some pockets where paramedic level first response or even ambulance service may be appropriate. But now it would only be a guess that I think is irresponsible for me to make.
Thank you. Thank you, Mr. Mayor.
Thank you, Mr. Mayor. I'd like to hear from Chief Moore, if we could, on our responses. The same question that was asked of Reno and Sparks.
Good morning. For the record, Fire Chief Charlie Moore, Truckee Meadows Fire District. Commissioner, your question was the number of responses, total responses. For the first 6 months of our operations, approximately 3,000, so we forecast about 6,000 per year.
Okay, thank you. My next question is for Dr. Cohen. Could you quickly, in just a brief, what do you consider first responders? And is law enforcement considered part of the law enforcement, or considered part of first responders?
The answer is anyone who chooses to respond to emergencies, whether they be the school nurse, whether they be an industrial plant that has an industrial brigade team of employees who happen to be emergency responders or EMTs, whether it's the police department or whether it's the fire service, all of them are first responders. In most communities, the fire service has committed to that obligation. But getting trained care to people, even in high-rise buildings, the old fire concept of the floor captain, even if it's somebody who can get there and say, yes, you're sick, and call and say, I have a sick person, that's first response in and of itself. And in most times, the quicker you get there, the quicker the stabilization of the incident. And that's another thing that the future is beholding in EMS. It's not only who makes it to the ER, but also not only who survives to discharge, are they surviving upright, neurologically intact, back to taxpayer status, or are they on their back for the rest of their life? How about the fractured wrist that's angulated, and the EMT who treats that, and the painter is back to work 6 weeks earlier? We're still trying to figure out how to measure that, but it's starting to happen. So I think we haven't yet discovered the value of quick response and appropriate response to emergencies.
Thank you.
Other questions? Okay. That's not an action item, it's just for information. Now we'll go to number 7, presentation, discussion, potential direction to staff regarding an update.
Thank you.
Status report of the MS working group, including progress on previous directions related to recommendations from the 2012 Tri-Data Emergency Medical System report.
Good morning, Mr. Chair, members of the Board of County Commissioners, Reno and Sparks City Councils, Sheriff Mike Haley for the record. I'm here today presenting as chairman of the Dispatch Working Group. I will cover the actions of the Dispatch Working Group, key dates, mission of the group, actions taken, some recommendations on computer-aided dispatch and Pro QA, and I will make a request of you to continue to enable the Dispatch Working Group as they move to address future challenges within the communications arena. So some key dates. March 2011, Shared Services Committee took action to create the Dispatch Working Group. On March 28th, 2011, the Dispatch Working Group met for the first time. Members included key regional participants: fire, law enforcement, dispatch, IT, legal, medical, REMSA, and human resources. The diversity of the working group allowed considerable cooperation and coordination across all necessary functional and political boundaries. The mission of the working group was, and it changed over time, but the initial of the mission of the working group was to identify all of the challenges associated with consolidation of the City of Reno ECOM and the Washoe County Sheriff's Office Dispatch Center located in Incline Village, Nevada, and report our findings to the Shared Services Committee for recommended action by the affected cities and county. So actions taken towards this mission include the following. The working group developed a strategic plan for a single communication center that included a mission statement, vision statement, and long-term goals. They developed an action plan that included items such as lead and secondary responsibilities, due dates, timelines, and status reports. They developed a comprehensive emergency communications director's job description. They completed the detailed legal review, including Nevada revised statutes, Nevada administrative codes, review of governance models such as joint powers agreements, interlocal agreements, as may be necessary to operate a future communication center. This initial review has continued to guide the working group in the overall process to date. We developed 3 staffing plans with associated operational budgets, cost allocation formulas for principal agencies' costs, and user fees for non-participating agencies. As we continued our work, it did become clear to all members of the working group that both the political climate and the economic climate were not conducive to full consolidation of the Reno Ecom and Washoe County Sheriff's Detention Center. As that reality became evident, we updated the Shared Services Committee, and with their approval, we continued to work towards co-location rather than consolidation of our communication center. Shifting gears, the dispatch working group used much of their earlier efforts and began the co-location process with the approval of all governing bodies. On May 14, 2012, the Incline Village Communication Center closed, and the co-located agency opened what is now called the Regional Emergency Operations Center off Parr Boulevard, North Reno. So the efficiencies as a result of that co-location: we reduced the number of transferred calls between agencies. We reduced the number of dropped calls. We improved response times. We increased collaboration of interoperability and coordination among responding agencies. We enhanced the safety of emergency responders through shared communications. We consolidated many dispatch policies, dispatch procedures, and protocols. We consolidated some training and certification processes. We avoided higher IT connectivity, equipment, and maintenance costs. We increased dispatch resources available during major events and critical incidences. We were also able to develop furniture and equipment specification packages that resulted in combined agency competitive bidding. We upgraded connectivity to include fiber optic technology. We upgraded next generation 911, and we consolidated phone systems. All furniture, equipment, and technology replacements and/or upgrades were completed on time and on budget. We have established the groundwork for future consolidation in such areas as recruitment, background investigations, training, automated emergency medical dispatch, dispatch life support protocols, and we have a business model that will be revenue generating should other communication centers engage our co-located center. Now for a few comments related to CAD to CAD link and EMD or Pro QA. Communication centers, including the Reno Ecom and Washoe County Dispatch, perform many other functions other than emergency medical services. It is a portion of what dispatch centers do. Because communication centers perform many other dispatch functions, its business model, policies, procedures, protocols, and software must be aligned. It must be well understood, and it must be universally applied within the communication centers. A best practice would be to pull EMS functions into a combined communication center, i.e., REMSA would move their EMS dispatch center into the Regional Emergency Operations Center. If that cannot be achieved, then the alternative would be to create a CAD to CAD link between EMS ambulance service provider and the Regional Emergency Operations Center. If that is the approved upon approach, then the Regional Emergency Operations Center must be the point of contact for all originating calls and must retain the call until the call is completed, regardless if it's a police call, a fire call, or an EMS call. In doing so, the Regional Emergency Operations Center and REMSA can both see the call and add data to the call as updates are received. Doing so will also allow for a seamless collection of response data, something that we're not able to do today. It is important for you to know that at the present time, right now, the Regional Emergency Operations Center is funded via a grant to the City of Reno to upgrade Tiburon, our computer-aided dispatch system. As part of that upgrade, Tiburon will provide a true CAD-to-CAD link and integrate all response data. REMSA has offered to create a temporary CAD link as a test product and will work with dispatch personnel to approve that CAD link functionality. We appreciate this offer, but we understand that it will add additional duties to dispatch personnel, add more screens for dispatch personnel to look at, and require us to test a CAD link system when we already have funding in place to upgrade to a full CAD-to-CAD link. A temporary solution may be appropriate if a permanent solution is delayed in any way. As part of REMSA's offer to the working group, we did look at REMSA's CAD link. It was believed to be somewhat cumbersome for the reasons that we mentioned above, and it would require additional screens, as I mentioned, and it would produce a non-integrated, non-organized, weak data recoverable alternative to a true CAD-to-CAD link that is part of a Tiburon upgrade. But again, I have to indicate to you that if that upgrade on a CAD-to-CAD link is not done in a timely manner, then REMSA's offer may be prudent. While we very much appreciate the temporary solution REMSA has offered, we do not believe it is necessary that the current funding would allow for a permanent solution. We propose to you to accomplish that task through a authorization for us to upgrade to a CAD-to-CAD link as part of Tiburon's upgrade. We invite any provider of a CAD-to-CAD link, including NorthPoint, which is a current REMSA provider, to respond to any RFP that would be submitted. Please remember that CAD-to-CAD link is only required because we do not have a combined dispatch EMS center. Collecting data, dispatching valuable resources, monitoring responding units, and recovering data in a timely manner requires an integrated system that must integrate EMS calls along with all the other functionality of a center. We cannot have an EMS dispatch center that is not integrated into the city-county dispatch center. There must be a physical or a virtual EMS presence in that center using fully integrated CAD technology that populates all data fields in one area. Mr. Chairman, members of the council, the dispatch working group is asking for the following. We would like you to continue to empower the dispatch working group to continue already very good work. We are unified. We are on a unified path to create seamless delivery of police, fire, and EMS dispatch services, whether the EMS ambulance service provider is physically present in the communication center or whether they're virtually present. REMSA is an important part of that process. They provide necessary and valuable services, and they are part of the working group and they should remain part of the working group as we move forward. We look for you to give us direction and milestones so we can continue our work as evidenced by the work that you've already given us. We ask you to support a true CAD-to-CAD link. REMSA concurs with the need to have a CAD-to-CAD link and can submit, as I indicated before, a bid to any RFP that would be submitted as part of that process. I'll conclude by saying that the dispatch working group is a collection of basically the finest, most skilled and professional folks that I've had the pleasure to work with. I implore you to listen to them. They are the experts in the room. The work product that I have described is their work product, and I was fortunate enough to have the opportunity to watch them as they tackled this mission, and the region should be very, very proud of their efforts to date. That concludes my statements. We have members of the dispatch working group present to answer questions as the bodies may deem appropriate.
Questions from anybody? Ms. Jordan.
Thank you, Sheriff Haley. A question with regards to estimates on what the CAD-to-CAD link would cost and the timeline to implement.
I'll defer that question to, I think, Robert Chisel, who holds the grant through the City of Reno for that process.
Good morning, Robert Chisel, Finance Director for the City of Reno. We have an item before the City Council on Wednesday to accept a grant for approximately $796,000 for the upgrade of our Tiburon system, which is our dispatch, our computer-aided dispatch system that is jointly used by the Washoe County and the City of Reno. It also will allow for the City of Sparks to also come on that same system, and I do not know whether they have made that decision yet or not, but the upgrade would allow for that to occur, and it would allow for that CAD-to-CAD interface that we are talking about.
Do you think that the grant would cover the
grant will
cost?
cover the cost, yes.
And the estimated time of rollout?
You know, upgrading or changing anything to a dispatch system is not something you do overnight. It has to be done thoughtfully. I would probably estimate it's going to take about a year to accomplish the full upgrade of the system. It is not something we want to do quickly and without thought, so.
Ms. Jones?
Could you clarify something?
Thank you, Mr. Mayor. I have a question regarding the empowering this dispatch working group to move forward. Now, would we need the CAD-to-CAD link if we were co-located?
Robert Chisel again, no, we would not. If we were all in the same system, you would have no need for a CAD-to-CAD link.
And so who is this grant from?
This is from the Federal Department of Homeland Security through the State of Nevada Division of Emergency Management.
So it's more taxpayers'
yes.
money. Okay. And I didn't get from your presentation, Mr. Sheriff, exactly what the resistance was to co-location.
Well, there wasn't a resistance to co-location. What I tried to indicate is that we were looking for a consolidation of all regions' dispatch centers into one major center. That wasn't achievable for lots of reasons. So we were subsequently authorized to co-locate those folks who wanted to co-locate at the present time. Am I answering your question?
Maybe I need a REMSA representative to ask that question, to answer that question.
Co-location of REMSA?
Right.
Okay.
Good morning, Jim Goebbels, for the record, President of REMSA and CareFlight. This discussion's been going on for some time, and the fact that in today's age, like the Sheriff said, you don't have to be in the same building to still share information back and forth. We do have two computer systems. They have Tiburon and we have TriTech. These two computer systems have merged virtually in other communities in the country. And now that Tiburon is being updated, we have the opportunity to get a true CAD-to-CAD link through our two computer systems. This link goes beyond just RenoCom and the Sheriff's Service and ours. This also has the potential ability then to link also with Sparks Dispatch Center at the same time. We both have infrastructure that is built out to run our operations, and REMSA does have an extensive infrastructure in running its medical dispatch center. And also that piece is the one that makes our overall operation work. So did that answer your question?
So you don't want to co-locate in the same building because
Well, right now.
there's not room? I mean,
Right now,
there's-
there is, and the sheriff will have to speak to that directly, but right now, the sheriff is trying to make that, and I'll use the term infusion center, where the Nevada Highway Patrol is also interested in coming in. And again, I do serve on the dispatch steering committee. I have for an extended period of time. And NDOT, there's also some discussions with that. So again, in today's technology, you don't have to be in the same location. Right now, the sheriff does have some interested parties in moving and actually expanding that dispatch center that's located there.
But again, Mr. Goopels, I don't understand why you wouldn't want to move your staff in there instead of spending this money of the virtual
Right now, because
co-locate.
we feel that it's not necessary with the virtual CAD link that we can do between our services, and that we still maintain the medical dispatch component for our services at REMSA.
So you like being separate and in a different building because
At
of
the
your
current time,
software
because-
or?
Right, because of different software. Even if we were in the same building, we still have two CAD systems. Those two CAD systems have to be connected. So that virtual connection has to happen, even if we were in the same building.
Okay, I have another question about the CAD to CAD and your software, et cetera. Who owns that? Your dispatch center?
The dispatch center is
Uh-huh.
owned and operated by REMSA.
Okay, but I understand according to the franchise agreement, should REMSA decide to not be in this community anymore, isn't it indeed the fact that the District Board of Health reverts back and we are responsible for all of your capital?
You are not responsible for all of our capital according to Section 30. If you chose to take us over, then again, there's a responsibility. But right now, that debt goes to REMSA. So that debt does not go back to the individual jurisdictions.
Is that how we understand it from our legal team?
Good morning. For the record, Leslie
Get a little closer to the mic, please.
Leslie Admiran, Deputy District Attorney. Pursuant to the interlocal agreement, if the Board of Health took over running REMSA, then yes, pursuant to the terms, they would be responsible for all the debts. But it specifies that it's the successor in interest, so it may not be the District Board of Health.
Who would it be?
At this point in time, I can't give you a definite answer as to who the successor would be. If there is an emergency and the District Board of Health needed to take over the running of the franchise, they could, pursuant to the terms of the interlocal agreement.
What if REMSA decided to leave town and shut down?
Right.
Who's responsible for the debt of the capital?
The successor in interest, and if that becomes the Board of Health, then that is the entity that would be responsible.
But isn't there contract with the District Board of Health?
It is.
So the successor of interest would be?
It could be, you could let out a contract to have another company come in and run the ambulance franchise, and then that company, pursuant to the agreement, would take over the debt.
And in the interim, while we were looking for a company to take it over, who would be servicing the debt?
I would say the District Board of Health would.
Okay, thank you. That's my question. Thank you, Mr. Mayor.
Okay. Ms. Sheevy.
What if the CAD link were to go down? Wouldn't it be beneficial if you were in the same building?
Again, it wouldn't matter if we were in the same building or not. We still have two distinct computer systems. Tiburon is more police-based. 80% of the calls that go into a 911 center are for law enforcement. With the TriCAD, it is more medical-based, and that's why those two distinct functions still occur between those two CADs. But they have been and can be linked so that information is shared immediately back and forth.
Well, there's a Girl Scout on the end. Please speak up.
Thank you. And I know Dr. Hess was trying to get in as well, so I don't know if you had seen Dr. Hess, but I'll ask a quick question and then just let you know that he was waving his hand too.
Well, I didn't see his hand move. I'm sorry.
That's okay. So Thank you, Mr. Gribbles. I was actually going back to Sheriff Haley.
Thank you.
You're welcome. Couple things, Sheriff. First of all, to be, I guess, a little bit frank, we received a report in our packet that was highly critical of ECOM's ability to handle emergency medical service calls in particular. And so I'm curious about, I know it's relatively new that everybody's working together, but I'm curious about your assessment of the overall capabilities to handle EMS calls for ECOM.
I think that either emerged out of the WASCO or the Fitch report.
One of the two, yes.
It didn't emerge out of the Tridata report.
Correct.
And as I have been told in my discussions with REMSA, that report reflected a pre-co-location analysis.
Okay. And so are you comfortable with ECOM's ability to handle
I'm
EMS calls?
extraordinarily comfortable with ECOM's ability to handle dispatch functionality across the broad spectrum. But unless and until we arrive at a unified software package that allows us all to see data, then we can only guess about how we're managing the EMS side of the dispatch function.
Okay, great, thank you. And then next question would be, in terms of co-location, I understand the benefits of co-location, and I understand Commissioner Jung's line of thinking. But when we're talking about what ifs, I think another thing that needs to be considered on a co-location issue is that should you have a major emergency that takes that center out, having an off-site provider where you do have a good CAD-to-CAD link does provide for redundancy in the system. And so is that, I mean, do you disagree with that? Is that something that you consider?
Actually, a REMSA would not be the fallback PSAP for that redundancy. It would be Sparks. If Sparks comes onto the same platform and the same EMS platform.
Correct. And so then I just want to make sure that what I heard, so the Tiburon grant allows the opportunity for the city of Sparks to come onto the same platform and then therefore be that redundant system that would be a backup to, should, the worst case ever happen and the main dispatch center goes down.
That's correct. And to follow up on Commissioner Jung's comment is that CAD-to-CAD links are only necessary if two people decide to have different CADs. I fully understand and respect REMSA's financial decision to remain on an EMS CAD that they like and that performs well for them. So whether they're virtually in the center or actually in the center, it would still require that CAD-to-CAD link. The only way to address that fully would be for everybody to be on the same CAD system that had an EMS functionality as part of it, that everybody could live with. And as part of our upgrade, the PSAPs will have a upgraded system that will have an EMS functionality to it that would work well for us.
Okay. And then one final question, if I may. Sure. My main interest in this topic has been for some time governance and the ability to govern. And I agree with many of the recommendations in several of the reports, frankly, that say that there is limited opportunity for those of us who are sitting in a governance function, whether it be as a city council member over a fire department or as a Board of Health member over a franchise agreement with an EMS provider. I see the main barrier to good governance being transparent and unified reporting of data. So my final question for you is, do you see a path forward that would allow for us to have that transparent, unified reporting of data that would allow all of us, regardless of whether we change the current governance systems or structures, to have the information that we need to compare one system against another, to see if they're working together well, to see probably most importantly that we're achieving better patient outcomes. Do you see a path forward?
Well, I would not
even if the
want
details
to,
of it are not quite in place yet.
I would not want to make comment on delivery of EMS service from a patient perspective. I'm not qualified to do that. I will respond to you by saying that if this working group continues to be enabled, if we continue to move towards a regionalized data CAD system that includes a regionalized EMS capability, then all of the data that would be necessary for this collective body to make decisions on would be available to do that in one place. And we have to do that. Right now it's in multiple locations and not clearly identified about what links up as a call together. So yes, it is achievable. We're moving in that direction. We believe that it will aid not only yourselves, but also enable and aid REMSA in the performance of their function.
So you said in your report that you were looking for direction, and that would be the direction that I would offer, is that we allow that working group to continue to get to a place where we have shared data. Because frankly, I don't know how we make good decisions until we have that accomplished.
And I think that since these items today are for information only, there's no action. So we'd have to go back to each of our councils at our next meetings and give those directions.
That would just be the world according to Julia.
Yes. Doctor.
Actually, the sheriff answered my question.
Okay.
Thank you, Doctor.
I apologize. Yes, sir.
Yes.
I didn't call you doctor.
Matt Smith, Chairman of the Board of Health. I have one question. When you get the CAD to CAD, does the information go both ways, or does it go one way? So whatever happens at REMSA, do you get that information, and do they get your information, or how does that work?
Well, let me step back, if I may. The system that we collectively looked at REMSA is a CAD link. It's a one-way shot that does, though, provide some functionality back. In other words, we can see the data, we can see status, and we can make decisions based on what we see, and we can respond back in a way that kind of aids us in understanding where REMSA is, what they're doing, and other things surrounding the EMS process. But it is not a true CAD to CAD link, and as indicated before, what we do as a temporary solution does not put any of that data in a central location for all of us to look at simultaneously.
That's the question. Once it's CAD to CAD, you get all that information. Is that correct?
Once it's CAD to CAD, then folks a lot smarter than myself can write crystal reports to extract the data out of that CAD system to answer virtually any question we have.
I think that is, I would support what the sheriff is asking for here, because the councils and the commissions, if you don't have the information, you're shooting in the dark. And once you have the information, you can find out where the problems are and you can start working on them. As it is right now, you don't have that information to really make those decisions. So
If I may Doctor, add to that, Mr. Chair?
Yes.
Washoe County and Reno have been on Tiburon's CAD system for many, many, many years. I use that information gathering system to run the Washoe County Sheriff's Office and to understand everything that occurs around our performance levels. We can write reports to that. We can ask the computer to give us information as we believe it's important to our decision making.
Ron?
Thank you, Mr. Mayor. This is a question of procedure in terms of bringing the issue of the working group back to each one of our respective groups. Do we vote on it individually, or are we going to vote on it today? And is the District Board of Health part of that? Because now we have 4 groups, and if 2 decide yes and 2 decide no, how do we deal with that?
Mr. Mayor, Manager Klinger.
Yes, sir.
I just wanted to clarify your comments on the agenda. The City of Reno, when we posted the agenda, we did not post those items for possible action, but both the county and the City of Sparks did post it for possible action, and I'm not sure about the District Board of Health, so I just wanted to clarify that.
Okay. Yes. Is your mic on?
Just a quick question. This subcommittee was formed through the Shared Services Committee. Is that the proper place for it to continue continue your work? Is that where the committee is actually supposed to make these directions? I don't think it's a problem with the Shared Services Committee to do that. I'm just saying that this committee was born out of that Shared Services Committee. Is it appropriate for the councils then to be telling the Shared Services people what to do? Just a procedural question.
Mr. Chair, if that's a question to me, I believe that the dispatch working group is the place that all of the work can be done because it has the right technical people, the right legal people, health experts, both our human resources folks. It has the right people representing all of the bodies that are sitting here today in one room. And then that work goes to the Shared Service Committee, which is comprised of select members of these bodies to advise their councils and Board of County Commissioners. And if I may add one other thing is that I forgot to indicate that Tiburon is also used by the North Lake Tahoe Fire Protection District as well as Pro-QA.
Mr. Smith?
Thank you, Mr. Mayor. Sheriff, NDOT's been advocating for Emergency Operations Center for the last several years as they have built in Las Vegas, but that was federally funded. Are you advocating for a new center, or is Parr Boulevard acceptable?
I am advocating for the Department of Transportation to place a building on the property of the current Reno Ecom EOC for the purposes of creating what's termed a FAST center that would then allow for the data side, not just the voice side, but the data side of our industry to move forward. I'm also on the board of the Tahoe Reno Tahoe Interoperability Project, the Department of Transportation Project. We have met with the Regional Public Safety Training Center to gain guidance, managers and executive board to gain guidance. They've continued to provide us guidance, and there's a high level of interest in building that particular center as part of the campus of all of our dispatch centers in the region.
Well, I know that RTC has denied, NDOT's request for support because of the cost of the building. How much is your building going to cost, and who's going to fund it?
Well, I would not want to speak for NDOT. NDOT is currently going through the Interim Finance Committee process. They believe that they have planning money available to plan the project, but that's a decision that the governor has influence on and subsequently will make through that state process. We believe it's important. We've informed the governor we believe it's important. The governor is taking that under consideration. And funding would probably come out of DOT funds, but again, I would be dangerous for me to wade down that path.
Okay, and I've heard figures upward of $50 million to build one of those centers.
I could not respond to that. I can tell you in the interim, though, and this is a long-term interim, is that we have a fabulous facility. It is run exceptionally well. It is becoming too small. So we have to find a solution fairly quickly to that space utilization within the EOC dispatch area.
Okay, thank you, Sheriff.
Thank you,
Mr. Dortch.
Thank you, Mr. Mayor. Sheriff, in all the conversations with your working group, has there been any consideration of making REMSA primary emergency medical dispatch?
There has been that discussion, and it's the opinion of the entire working group that cities and counties own these calls. Cities and counties have the liability for these calls, irregardless of what may be a counter opinion on that. Cities and counties need to know what happened at the beginning, and the middle, and the end. Cities and counties will go to court. Cities and counties need to be able to deflect legal claims of not being able to provide a unified, well-understood, data-supported system. So we would not recommend support of that.
If we have the CAD-to-CAD system in place, would that make more sense at that point in time?
No, it would not, because, as I said before, let's give you an example. Let's say we have an EMS call going directly to REMSA. Somebody picks up the phone and calls REMSA directly. All of us in the public safety industry have no knowledge that that's occurring. We are not collecting the data. We don't know how their response integrates with everybody else's potential response. We don't know if REMSA gets there, if there's a police, fire, or other emergency associated or eventually associated with the EMS call. Only after the fact would that be, or later in the call, would that become apparent, and then we would have lost all that data. It has to be integrated in one spot. The data has to be integrated in one spot. Now, I'm not here to say that REMSA should not be the primary responder or fire the secondary responder. I'm just here to say that we can't allow REMSA to be the point of contact for emergency calls, because emergency calls...
Well, no, my thought is that the call comes into the center.
Yes.
Police, fire,
EMS.
or medical.
Yes.
If it's medical, at that point in time, we shoot it straight to REMSA.
Yes and no.
We don't now, currently. I'm saying, why don't we?
Because we are the collector of the data. We have to be able to respond to all kinds of questions relative to on-scene times, to upgrades or downgrades of the call. And that isn't, if we get a phone call, that doesn't go into our system. It's not easily integrated into our system. So REMSA may have the call. REMSA may be responding. We may tell REMSA via the computer to respond. But then when they respond, everything they do is subsequently captured in a central point. If we pass the call on, it's not captured. It's only captured at REMSA.
But it would be under the new system if we have this new CAD-to-CAD system in place. They could capture the data just as simply as we do.
What would happen, Councilman Dortch, is that both county or regional dispatch center and the EMS provider would be able to add to that call simultaneously. They would both be able to enter data into that call in one point. They would enter their relevant data, we would enter our relevant data, or follow up with police or fire if we're seeing things evolve to that eventuality.
Right. But again, I guess that's my point is, they should be the primary responder, so shouldn't they get the call first? So if it's a medical response, let's get it to them as quickly as possible. Right now, there's about almost a 2-minute delay in them getting the response. So we're rolling fire, which is why fire's at our calls more often than not first. They get the call late, and then they roll. If they get the call first, they can determine whether or not, because they know where all their trucks are. I mean, they know exactly where they're at. They can determine if we need fire to roll or not, which would save our resources.
That is achievable, Councilman Dortch, but the PSAP has to be the point of initial call. Fire, police, ambulance.
I don't disagree, but as soon as we know it's medical, we could shoot it to them.
If, and you're exactly correct, if we have a system that collects that data at a central point, and I'm just saying that that central point has to be here. Yes, we do transfer the call. We need to do it very rapidly. and then we need to follow that call as it's moving forward. And I think what you're maybe getting into is, you know.
I'm sorry, they've got the personnel, they've got the emergency medical dispatchers, and at that point in time, we wouldn't need emergency medical dispatchers. I mean, it would save our resources, it would save our fire resources in situations where we don't need to roll our fire trucks on every call, and they would make that determination.
I would defer this particular question to our fire providers if you would like them to talk about it, the
Well,
chiefs.
I think it's more of a public policy decision. I mean, I think it's up to us to make that decision.
I do, but I think they're more able to speak to their response with respect to EMS as I would.
I mean, I'm happy to hear from my chief. I mean, if you want to, Chief Fernandez, if you want to respond to that. But at the end of the day, I mean, I think it's more of a resources issue, and you know, we need to make that decision as a public body.
Doctor, do you have a comment? Come up, please.
Okay. Dr. Harold Cohen, I really have to tell you, I think you're in a better position to support the sheriffs working with this, because as the councilman said, from a technical point, yes, you can get the call at the same time. It's automatically transferred. Why not do it? But you have to look at the whole system and see what is REMSA or RASI or whomever. They're vendors. And when it comes to critical public safety, there is no way you can put yourself at risk that what if the vendor doesn't show up? Oh, that's never going to happen. Are they too big to fail? I believe it would not be appropriate to take that. And also remember, you're dealing with dispatching EMS and other agencies. North Lake Tahoe, Gerlach. I would be more wondering, is that issue going to come with Gerlach? Is that going to become a problem that you have to take action on here? But I have to agree with the sheriff on this. It has to start at the top, and they will assign people. The CAD to CAD will assign those calls quicker, and they can get on it. They don't have to wait the 2.5 minutes, whatever it is, to do that. So I think there's safety in both of those processes, and you have both organizations able to do that. I'm not sure giving up that oversight is in the best interest of the patient and everybody else.
Thank you, sir.
Dr. Cohen, question for you. If the councilman is looking to cut back on the fire service to respond to everyone, could you put a protocol on it? That there has to be a certain amount of protocol for the fire to decide to go?
I think there is. We've been talking about it all morning, and that is the medical priority dispatch program with ProQA. That has already picked out the most serious calls as the minimum first response.
But they're running on everything, including that.
And that is a local. I believe that is a local decision.
So that's what they could do.
Yes. Yes, that the county commissioners and the oversight agency for EMS can say, this is what we want a first responder on. The local jurisdiction can do it, feels it's in the best interest of the citizens at their cost.
Chief Hernandez, you had something?
Thank you.
For the record, Mike Hernandez, Reno Fire Chief. Councilmember Dortch, did you need to seek further clarification, or do you want my opinion, or?
Sure, I'd like to hear what you have to say.
Currently, the way our system works within the city of Reno, Mr. Mayor, members of the council board, that call hits our, well, we have a bifurcated system, actually. Some calls go directly to REMSA. Some calls come to our public safety access point, our Reno Ecom. That call, on average, we've been tracking some of our call transfer times. We're right at about a minute and 15 seconds from the time we answer the call to the time it's transferred over to the REMSA side. We pull out critical pieces of information: name, address, what's your emergency, and how serious is it, and it's immediately transferred over to the REMSA system. And that's where the separation of data, that's where the separation of information begins. We immediately dispatched an engine company. To your point, that's why we're arriving quickly. Again, we're arriving under 6 minutes. I'm very proud of that fact. The Tri-Data report that indicated that we were slow out of the station has been addressed. Our responders are responding quickly and timely, and we're touching that patient within an 8-minute response criteria that we have set within our system. With respect to emergency medical dispatch, prioritization of calls, that's currently occurring, again, partially at Reno Ecom through the North Lake Tahoe system, because that's their system that they have brought down off the mountain. And then it's occurring within the REMSA system. And I don't want to speak to the REMSA, how they do it, but they do, clearly they do an effective job. But right now our systems are complementary. Can we do a better job? Absolutely. Ultimately, it is our goal within the Reno Fire Department to give all of our citizens the highest level of first response care that we can. And we, since my arrival, my position has been, and my administration has been, to complement and enhance the existing EMS system that we currently have. I call it a plug-and-play system. I want our responders to be trained to the same level as the REMSA system is. I want our equipment to be compatible so that they literally show up, we unplug our stuff, and we plug it into theirs. The transfer time is minimal. Again, the objective is to get that patient to the emergency care facility within that golden hour so that their survivability rate is greatly enhanced. So again, that's how we are currently working. Can it be improved? Absolutely. And I would advocate that we continue to empower the dispatch working group to do the good work that they're doing and allow us to continue to improve our system.
Ms. Reddy?
I was just looking for a clarification. I believe that we're only halfway through this agenda item, in that there's still a presentation from the managers on all of the recommendations. So this is specific. We've been spending a lot of time on dispatch, and certainly dispatch is an important part of the recommendations that came out of the Tri-Data report. But before we take any direction, I do think we should hear the other staff report, which is the entirety of the recommendations, so that we don't get too hung up on dispatch and forget about all the other recommendations that are in the report. So I just want to make sure there's still another, on this agenda item, there's still another report, which is from the managers on the work that they've been doing.
Naomi?
I just have a question of fire. There was recently a pie chart that was in the Reno Gazette-Journal that broke out the percentage and the volume of calls that fire responded to. A significant percentage of that was EMS responses, and I want to know, out of that figure, how many were you canceled on that were included, and who cancels? Who cancels? I understand that calls come in, and then it's determined as the information is acquired what the type of emergency is. Who has the capability of canceling a ladder truck or a fire truck if it is determined that it's a non-fire-related or necessary issue?
Once again, for the record, Mike Hernandez, Reno Fire Chief. Again, roughly 20% of all of our calls are fire-based. 80% of what we respond to is EMS. I hope Beryl Love isn't watching this, but I don't actually subscribe to the Reno Gazette, so I didn't see that particular article.
But wait until you read the article.
There's Brian Dugan back there. However, I can tell you this. It is a mutually beneficial activity that occurs. There are times when Reno Fire arrives and has that capability to either cancel or downgrade the response to REMSA via a report that the patient isn't critical, that the patient is stable, what was once reported or what was reported through the dispatch system was inaccurate, and that we have stabilized the patient so we can actually either decrease or the patient can state, I do not want to go to the hospital. And we can actually cancel the REMSA response. Likewise, REMSA has the capability to arrive on scene. They are capable of making that EMS determination, and they will likewise cancel. So it is a mutually shared responsibility with respect to who can cancel who. Depending on who arrives first, they can make that determination and proceed accordingly. So it is, I would argue that it is a mutually beneficial action that both entities can take.
Okay.
I'm sorry.
Go ahead.
I was going to say, if you'd like data with respect to the number of times canceled, we can go back and query that for a 30-day period, 60-day period, if that's your direction.
Okay, the other question I have is, my understanding of response times and REMSA being slightly behind fire's on-scene arrival time, can you attribute that to the two-step dispatch connection? Is there any correlation of how that gap would be closed by having one central?
Oh, sir, I would argue and I would support the fact that a virtual CAD-to-CAD link, a computer-aided dispatching system would certainly decrease that time. Right now, again, from what we've been able to gather, our transfer time is just a little over a minute and 15 seconds from the time that phone is answered to the time it's pushed off to the EMS provider. We begin our response. I think that if we were to have that virtual connectivity, that what we are entering into our system to dispatch our side of the fence, they are seeing on their side of the fence as well. So I would argue that it would certainly impact our response times considerably.
Thank you.
Ron?
Thank you, Mr. Mayor. No. Thank you, Chief. Sheriff Haley, a scenario such as this, and this is where I think it's important for your office to handle calls or the governmental agency to handle calls initially. I call up and I say, I'm cut, I'm bleeding. And if REMSA is immediately dispatched and perhaps I don't fill in the information quick enough that somebody cut me and this person and you guys need to come and clear the scene, now you have fire and REMSA showing up before the scene is cleared.
You're exactly right, and that's why you need to have the point of data collection in one spot, for two reasons. One, it integrates all governmental and contract employees' response, contract agencies' response, integrates it in one place. Who goes to that call is derived from that initial call, that initial collection of data, and then as we go forward, all subsequent data is collected in one spot. The questions I saw earlier of the fire folks, and we could ask the same of EMS folks and police folks, is the who, what, why, where, and when. Now is open to a large amount of conjecture, because it's not collected in one spot and it's not extracted in a universally accepted and understood manner as its nexus between our other agencies are considered.
And I think, Mr. Goebbels, you would agree you would not want to send your paramedics into a scene that was not cleared first. Thank you, Sheriff.
Thank you very much.
Mr. Smith?
You know, just a comment. I think that if we have a citizen that is in need or is in stress, they don't care who shows up, whether it's the fire department or REMSA. They need care, and it's a temporary thing till REMSA gets there. But I do know that in the city of Sparks, that if there's an emergency or a medical call, we want to know about it. We don't want the calls to go directly to REMSA. And right now, I believe it goes to our dispatch and REMSA at the same time. A delay in let's say response time may be caused by we classify it differently than what REMSA does, but we always respond.
Absolutely, and we're not all talking on the same platform of technology, nor data collection, nor are we writing our requests for information from that system in the same way.
Right. Thank you.
Thank you.
Okay. Kitty?
Thank you, Mr. Mayor. Just a point of clarification, when we're talking about the dispatch center, it's on Spectrum, right? Not PAR?
It's on Spectrum. I
Okay.
said PAR north of Reno.
Okay, good.
Thank you.
No, thank you. I have a question for both you and your dispatch and REMSA's dispatch in terms of how old is your software?
We have somebody in the back of the room that could tell you that right at the beginning.
And here he comes.
Here he comes.
For the record, Daniel Johnson, Manager of Emergency Communications and Technology for the City of Reno. The current Tiburon system we've had in place since 2001. We have gone through a series of upgrades with it. The current version that we are on is a Unix-based version, the end of life in 2015.
Okay, so it's the legacy system that you expect to have to relicense, re-upgrade, whatever.
Well, that's what the grant is for, and we're upgrading that system so that the system that we will have will be the current version of the Tiburon Public Safety System. So we will no longer be on a legacy system of theirs that they will no longer support soon. So that's the purpose of securing that grant and upgrading our system.
And you said it will last till 2015?
The current system. The Tiburon has given a letter of end of support for our current Unix-based system of 2015. The upgraded system is their current system that they're supporting going forward.
And how much will that cost?
That's the grant for $797,000.
Okay, great. And then
that's the upgrade. That takes care of that.
Gotcha. Thank you. Mr. Goebbels, what about your software and your licensing?
For the record, Jim Goebbels, President of REMSA. Our latest upgrade on our TriTech was within the last year.
And what's the life expectancy of that?
Oh, the life expectancy for the overall program, it's ongoing as long as those upgrades are kept in place.
How often do you have to do relicensing or upgrading?
Pardon me?
How often do you have to relicense or upgrade?
Well, this last one was within a year. Usually, upgrades of this magnitude for major upgrades will happen within about every 2 years.
So is there a possibility that the two of you could work together if this is coming up the next couple of years to pick a platform that you both can agree on or migrate over to our platform?
You know, I think at this point, again, the decision was to stay with Tiburon up at ECOM and the sheriff's system. The compatibility between Tiburon and TriTech are there. It's already been done as far as doing virtual. So I'm not concerned that as long as we both keep our upgrades, then that compatibility is there.
Okay, great. I have one other question for you. Going back to capital and debt and that the District Board of Health would absorb it, what is your debt level and your capital level, like monthly payment? Just to see if the Board of Health could afford it.
I just took over this position 3 weeks ago, okay? I am not up to speed on our total financials, and I can certainly get back to you. But
could we have that at the next Board of Health as part of your presentation?
I believe I can probably do that.
Okay, great.
All right,
thank you.
thank you.
Thank you, Mr. Mayor.
This question's for Mr. Chisel or Mr. Klinger. I was going to ask this at caucus, but I'll ask this now. In terms of the Tiburon grant that we're set to approve on Wednesday, will we need additional human resources in IT to bring this project on? We've cut back so significantly in that division.
This is Robert Chisel, Finance Director, for the record. We will be utilizing our internal staff to do the upgrade with the Washoe County IT staff. We believe we can do it with the current staffing levels we have. Part of the upgrade is Tiburon coming in and providing assistance too. So it will be a combined effort. Yes, we have cut back significantly, but we can prioritize this endeavor, and we think we can get it done with their current staffing levels.
Any other questions? All right. Let's move on to the next item. Yes?
So that was my question is, I'm a little confused on the agenda. So number 7 is the presentation, that's the item that we're on now? Or we're still on 6? Or I have the wrong agenda?
Next time we got to send out one agenda for everybody.
So my understanding, and somebody, perhaps Sean, you can answer this question for me, is that, so we just heard the dispatch portion of the update, but are we going to hear the update from the managers on all of the other parts of the Tri-Data recommendations?
You'll find a second attachment to item 7, which follows the presentation by REMSA. As you know, REMSA has come forward and responded to the actions that they took in response to your joint meeting in October, where they're coming forward and saying we want to be part of the EMS solution. And Mr. Jim Goebbels is here today. He brought along a couple of reports which are in your agenda item, so it would be appropriate to hear from him. And then the managers in the second attachment, item 7, we do have a wrap-up for you, a path forward, a way to kind of take this on and move this ball down the road so that we get solutions in the near term.
So to be clear, we're going to move off of 7, allow REMSA their time, and then move back to 7
Yes.
to
Yeah, it's an
hear from the
attachment to
manager.
number 7. So
We're going to have an update from the Regional Emergency Medical Services Authority, REMSA, including but not limited to REMSA's staff response to the 2012 Tri-Data Emergency Medical System.
And you'll excuse my concern, we had a recent meeting at the Board of Health where we moved off an agenda item and we were not able to go back to it. So I just want to make absolutely certain that if we're moving off of 7, we're able to go back to it today.
We will. We're going to run by Robert's Rules of Order, so we'll go back to it. Go ahead, sir.
Good morning. For the record, again, Jim Goebbels, president of REMSA and CareFlight. Thank you, mayors and Matt Smith, for being here along with the councils and all 4 boards to talk a little bit about where our process is. You do have in your board packet, again, 2 additional consultant reports on our current EMS system, and also a cover letter that I sent to Matt Smith as chairman of the District Board of Health. I do encourage you to read those reports for additional information. It's also important to point out, and some of these discussions have already occurred, that there's been multiple reports over our EMS system in the last few years, including ones, from the county and REMSA itself, but they have resulted in some very common findings and recommendations. To date, very few of those recommendations have been acted on. And again, even those reports have expanded over 19 years. There's been many reasons for this, including territorial and protective positions taken by both the fire services and by REMSA. And we do need to look at changing that philosophy and process. Right now, I'm here today to tell you that there is a change in leadership at REMSA, and that change in leadership is through myself. And there's also a change and shift in the philosophy and approach of the REMSA Board of Directors. Some of those directors joined us today for this meeting. We will commit to a renewed spirit of openness and transparency and cooperation with an end goal of promoting new ideas towards excellence in our system of pre-hospital medical care. In this spirit of cooperation, we intend to be transparent in our interactions with our EMS system partners and hope for the same transparency and cooperation in return. We welcome the opportunity to sit at the table with the county and the city managers, along with our fire chiefs, and move forward to make a genuine difference in improving our overall system, including the REMSA side, including the fire side. In reviewing, and I have, there's 6 of them, in reviewing all 6 of these reports that most recently have come out, there really is 3 common themes. One is on communication and dispatch, one is on medical direction, and one is on regional coordination and operations. I think we can look at a lot of these because we haven't set priorities and we haven't moved forward. So in the letter that was presented, I did put down what I feel are some of the priorities that we actually can move forward on. Dispatch being one. Some of that we talked a lot about today, but let's set some standards. And those standards are there. We don't have to create them. The standards are already developed by the NFPA standards, and they're very clear in their 1710 as far as how a primary 911 center works and how a secondary 911 center works, which is what REMSA is. The CAD to CAD, we've not been able to do, and it's because of technology. But now, because we can move forward and update Tiburon, that can happen. There is also an interim product out there that will help us stop the phone calls back and forth. And as the sheriff said, I encourage that we look at that product. It's more like instant messaging, but guess what? It's a whole lot faster than a human being on one side calling another human being on the other side to get information passed. So hopefully we can look at least using this interim product to do that. We really do need to focus more on emergency medical dispatch. We've talked about it in this room, but emergency medical dispatch is more than just that person. It's that person given pre-arrival instructions. It's that paramedic or EMT that's on the line before fire gets there, before REMSA gets there, that can give you instructions that deal with that life or limb-threatening situation or minor situation until we get there. Can we be more efficient and appropriate with our resources? Yeah. And do we really look at identifying data that we can share back and, again, do that off standards base? Medical direction, we've talked about it again. We need to put it back on the table. It makes sense to have one central medical director. Should we have common field protocols? Even Dennis Jacobson said, yeah, we need to. We started that process already. We need to complete that process. What we do for reviewing our clinical cases, yeah, we need to do it together. There are some HIPAA problems. There are some reporting problems. I think we can work around those. And I think there's some mechanisms we can use in our community to do it. On our regional coordination and operations, we need to work together on legislation. You know, in California, there's actually a fine now for traffic moving violations that go back to EMS. We've never tried that here. We need to look at it. And again, it could be a component for moving violations that could support both sides of the EMS system. We need to look at what our first responder, and when I use the term first responder, it's fire first responder, and what those service levels are. Can we really integrate our automatic vehicle locators? I think we can. And again, with the products that we have and moving forward, we can. Right now, REMSA reports into a national database called CARES, and it's cardiac resuscitation and outcome. We report our components. We don't report the fire first response components. Why don't we do that? We should. Why don't we look collectively at every cardiac arrest we have in our community and say, how could we have done it better on this side? How could we have done it better on this side? We need to move forward with those. Medical supply exchange policies and REMSA doing purchasing, again, makes sense. We haven't done this for years, folks. I mean, when I first came on board with REMSA 17 years ago, we did a supply exchange program. That goes back to 1996, and that's when only first response or EMT basic level was being done. We need to sit down with the fire chiefs and say, okay, what are we doing today? We're actually doing at the intermediate level. Then let's look at the supplies we're all using and needing, and let's see how we do it together and coordinate it. We need the same response time, and that's the one thing that's consistent through all the reports is the fact that REMSA does not report averages. REMSA reports what's called fractile. That means we count every case, and then it's an overall number. Right now, we need to do that with all of our first response and with REMSA. So when we're talking about a number, it's the same number consistent. Then we can actually study our system and where are the gaps. Where are the gaps between our fire first response and REMSA, and what do we need to fill those gaps? Then we can look at data and actually make sense and improve that. We're eager to get going on this. Enough talking, okay? So let's get going, and these are some short-term goals that are certainly achievable, is to look at an overall authority. And right now, that authority for REMSA is back to the District Board of Health. It makes sense to take the fire first response and also put that back to the District Board of Health. So we're reporting the same thing, and it's back to a medical body. This is medicine. Dr. Cohen will tell you that. This is the practice of medicine, and that's why it's so important it goes back through a medical board. The CAD to CAD we've already talked about as far as what we can do for responding quicker to calls, what we can do for our linkages back. And you know what we've never done, and I'm embarrassed, is the fire services do their promotional things back to our citizens. REMSA does its promotional things and education back to the community. Why in the world don't we stand side by side and do it jointly? We're all here to do the same thing. So I hope that you accept this letter in the spirit of cooperation, which is what it is intended to do. I do ask as we move forward that we really be able to participate, and we haven't been in the EMS working group to point. I hope that today is a start where we can do that, just like with the dispatch steering group that we work with the sheriff. But we really do want to build a spirit of mutual respect and cooperation and move forward on the things that we can move forward on. You know, last month I lost a friend, and he taught all 3 of my children up at McQueen High School. He was an excellent teacher. He actually coached 2 of my sons in a state championship football game. One of my sons is a state championship because of that coaching. One is a state runner-up. But what he did with those kids up there is he had a philosophy and a saying, and it was called RMA, and it stands for the right mental attitude. And he instilled that in my children and in part also in me. I think Dr. Cohen and the Tri-Data report has moved us all forward to have the right mental attitude so that the fire chiefs and REMSA, we're not talking about us and them anymore. We have a 2-tiered system here. It was always designed to be a 2-tiered system. In my opinion, it should be a 2-tiered system where we have fire first response here and REMSA ambulance response here working side by side to benefit our patients. The us and them has to go away. It's all in us. And that's what I ask that we move forward on. Thank you.
I do. Mr. Goebbels, I appreciate you coming to have a conversation with us, and I appreciated your letter. My intent is not to smack you or REMSA with a green stick. And you said you will commit to a renewed spirit of openness and cooperation. When the Tri-Data report came out, immediately you guys commissioned 2 reports from Washco and Fitch. And immediately in Washco's report, there appear to be numerous erroneous statements and references throughout the report that seem to demonstrate, and it goes on to list 6 things, and then what my point here is that you're talking about cooperation and you're saying let's cooperate, but immediately when some recommendations are made to make changes, you guys bring reports out that refute them and say, look, we've been doing things correctly all along. That's the inference that I got from these 2 reports. So, and let me just complete my thought. When a commissioned report like Tri-Data comes out, its intent is not to speak pejoratively about the way that REMSA has done business, but to bring us together and say, look, there are things that we can change. The most of which was a universal incident number. And I've heard you guys say, well, a universal incident number won't really be helpful.
And that's incorrect. And actually with CAD North, which is the system that the sheriff was discussing, that interim CAD link, that can unite our run numbers right now. Because what it does, it takes the REMSA run number and actually sends it to either Sparks 911 or Reno 911. Then they can do a match right there within their CAD. So that is achievable right now today. In the future, when we do a virtual CAD to CAD, then those numbers are linked without a human person having to touch them. Okay. They're already linked.
And I think that's great, and I look forward to that happening. But I guess what I would say just in closing is when there's a suggestion of change, you know, let's not commission these kinds of reports. I mean, that's tough for me because instead of saying, okay, let's look at these things individually and let's see what's being recommended, 38 recommendations. Let's look at them on an individual basis immediately. I mean, you know, you guys went out and spent a ton of money. I'm sure that this stuff was not free. So there's my 2 cents. I'm now broke.
And
Thank you.
again, those were started before that final report came out. And again, that's why that cover letter is there, because they are opinions. You can take those opinions and leave those opinions. They are opinions. What to me is important is the cover letter that I presented to Matt Smith.
Ms. Zadra?
Thank you, Mr. Mayor. My comments, really more than question, Mr. Goebbels, are similar but from a different perspective. I think that we heard very initially in our presentation today from Dr. Cohen that if nothing else, collaboration is the most important moving forward strategy that we can put into this. And I totally agree. And I think that we've seen a lack, somewhat of a lack, from all of the involved parties, the stakeholders and partners, including the working group that includes the managers and the mayors and chairmen. But it does not include, yet again, one more partner, RMSA. I think that really is a void. I thought that we had talked about that in one of our prior meetings to make sure that we had all of the players at the table, particularly in this critical time. I think what we're seeing is because we didn't have good communication, there were multiple reports coming out for different interpretation. But we need to have all of the partners, RMSA included, in that working group with the managers and the mayors and chairmen, so that we are covering all of our bases in this critical discovery and evaluation period. I really think they need to be at the table, and I think I understand they have not been. I think that's a shortcoming. And if we have all of the players at the table from this point forward, I believe we'll have fewer of these kinds of distracting reports. We'll have one unified approach.
Mr. Carey.
Thank you. To respond to that particular question, we are moving in a direction which is consistent from the actions and motions that were taken by the bodies. And we have brought together the Health Department, Reno, Sparks, and Washoe County, and the North Lake Tahoe Fire Protection District for the purpose of reviewing the recommendations and the information we have before us. It wasn't until we heard back from RMSA in recent times that they were willing to open up their discussions on the 3 things that you asked us to do. It was our job to find out what are the facts on the public safety provider side so that we could enter into negotiations with someone who is a very integral part to our community. Rest assured, RMSA is the solution to the problems that we have before us. And we intend to use a negotiation style that brings them to the table, and we work to have all the information from all parties. What you need as elected officials are recommendations from your managers and your health officer that look at these very complex issues and give you a recommendation, give you options, and give you pros and cons. And we intend to do that in short order by bringing RMSA to the table to join us as we take a consensus-based approach. This isn't one agency calling the shots. The way we're working as a working group is on consensus. Keep in mind, Dr. Cohen came up with 38 specific areas, and the 3 areas that those can be summarized into are dispatch, the RMSA franchise agreement, and what to do with EMS agency authority and oversight. Those are the big 3, and from that will come solutions to the 38 questions that we have before us. We're taking the opportunity to make sure we prioritize those. Look for possible solutions. Look for pros and cons. RMSA needs to be part of that process, fully always our intent. We use these early 2 meetings that we've had, and it's only been 2, in order for us to begin the process of laying out a framework. Dr. Iser and his staff have been instrumental in building a necessary tool for us to look at where each agency would support and comment on each of these 3 major topics. The answer for you, if I could, is to say that we need to address all 38 of these within the coming meetings of this joint body. Because it crosses so many departmental lines, and you heard from Sheriff Haley, there is so much technical expertise that's needed to get to the answer. We feel that the managers and the health officers, along with Jim Goebbels now as the RMSA president and the North Lake Tahoe fire chief, need to be in the room, and we need to solve this problem in the coming year so that you can make the directions known that will last our community for years to come.
Thank you, Mr. Manager. So do I hear that at this point forward, they will always be at the table as every other stakeholder has been.
They're a
They will
stakeholder.
be.
They're a stakeholder with the receipt of their letter. They're a stakeholder to join us at the table. We will have to have meetings on the public safety side of this as we look at our systems. Example, Sparks uses West Covina CAD system. Reno and Washoe have for years successfully used Tiburon. A lot of those things we need to do as managers, irrespective of the REMSA decision. And that's why the stakeholders must come together to set forth these kinds of platforms. Rest assured, Jim is an equal partner and an important stakeholder to find the solutions that are in that 38 level. No one's going to be dictating to him from this side of the table or that side of the table. He's joining a true consensus model where we'll bring back to you a recommendation that makes sense to those present, what are the pros and the cons, and really, for public policy members, what are the alternatives that you consider? That's what you can expect back from your working group.
Ms. Jordan.
I just need,
You had another?
yeah, I just need clarity. I'm still not sure I heard it. Will the working group that includes all of the managers that have met 2 times previously, will that now include REMSA
Yes.
so that every party
Yes.
is involved in every meeting?
To be absolutely clear, I'm going to say it twice, yes and yes.
Thank you. Thank you very much.
No. Would you like to speak? Go ahead.
I would. Thank you. A couple of questions. Well, first off, I appreciate the collaboration and the efforts towards working together to come up with a more efficient solution. And unlike Vaughn, I kind of like having multiple reports because I believe there's multiple sides to every story, and to have more data certainly isn't something that I look down upon or look at as a contradiction to an initial report. I truly believe there are multiple sides to every story, so I appreciate the multiple reports you've provided. One of the questions I have is, I go back to your medical supply exchange policies and REMSA doing the purchasing. Has there been any studies done that you have a stronger purchasing power and that you can get materials and supplies at a more cost-effective rate?
Again, for the record, Jim Goebbels. In the fire first response medical study, it was done in '94, and this is where it started from, is that REMSA, because of that study, and that was actually hosted by the District Board of Health, believe it or not, with hospitals, with fire, with police, with nurses, with physicians, that there be a one-on-one exchange between REMSA and the scene firefighters. But it was based on basic life supplies. Okay, so in other words, it was more soft goods. It was more dressings, seat collars, that type of thing. The other piece of that, so we did do agreements with, at that time, again, all 3 jurisdictions, actually 4 because NDF was into play then. So we did that so that it'd be a one-on-one exchange at the ambulance. The other piece of that was doing system-wide backboards. So REMSA purchased all the backboards. They went into the system, and that way, if a fire service already had someone backboarded, then they just take one of our backboards. They're all the same color. We would all work together to make sure they didn't go to Fernley or Urington. So if a firefighter saw one of our boards going out of town, he would grab it and, again, keep it back into the system. What we need to do today, that's all old stuff. We need to update it. And what I think we need to do, and I'll sit down with the fire chiefs if they want to move forward on that, and look at, number one, getting those basic supplies out there to be upgraded to the intermediate supply. And we don't do one-on-one exchange at the ambulance. That we actually coordinate it, that there be a list, and once a week you come over and that list gets filled at REMSA. Is there buying power through REMSA? Yeah, because we buy much larger supplies and volumes of even our IV equipment than the fire services would. So I think we can look at that and make it work for everybody.
Ms. Weber.
Thank you, Mr. Mayor. Well, I want to share with you something, Mr. Goebbels. I think having you at the head has been an awesome change for REMSA, and I want to say that to REMSA, thank you, to all of you, because this is the first time in over 10 years I think that somebody's actually come to the table and said, let's talk. And it's really great to have you here, to have REMSA here, and we have to do this as a team. We have to have all the players at the table and look forward to discussions, and hopefully it'll be sooner than later when some of this stuff gets done. Thanks.
Ms. Reddy. Scott?
So, Mr. Grubels, thank you for being here, and I appreciate all of the REMSA board members who've taken the time to be with us today. I also appreciate the change in tone. I'm sincere in saying that. I want to make sure, again, because much like you've said, we've had report after report after report, and we've had public meeting after public meeting after public meeting, and we've had statements of good intent, and I've seen the singing of Kumbaya almost at some meetings. But I'm looking for something concrete that again, and I think I'm very consistent on this. I always go back to, we need, both in my role as a city council member and my role in the Board of Health, the ability to govern. And the main thing that prevents me, in my opinion, from being able to govern at this point is transparency, and it's transparency of data. So I would just like to make sure that that tone and that spirit also includes a willingness to be transparent in every piece of data, unless it is specifically precluded. And I understand there's a handful of things, we've got some HIPAA issues, but no more of the, that's ours, it's not mandated in the franchise agreement, so therefore we don't have to share. And I fully recognize, and I'll say it before Mr. Smith has to say it for me, that we need that across the fire providers as well. We need a common data system. So does it have to be tomorrow? No, but when we get to a CAD-to-CAD link where everybody can see everything, that there's no walls put up in terms of data. And so if you're willing to commit to that, then I think that we can move forward, because frankly, everything else and every single report points to this is conjecture. Dr. Cohen can stand up there and he can say on a slide that we have good patient care, but it's anecdotal. We don't have anything that really, where we can report to the data across the system. We don't have anything that we can report to patient outcomes across the system. And I need that. And every Board of Health member that follows me will need that to be able to govern. So I'm asking you, I'm putting you on the spot a little bit, but I'm asking, are you committing to transparency of all data that can be transparent?
I am
including
committing,
financial.
I'm committed to, and our financials can be out there too. And if you want a copy of those, you can have those. What I ask, though, is that we measure the same. And Fractile doesn't take CAD to CAD, okay? Fractile is a mathematical calculation. And Fractiles can be used right now today to measure between all of our fire services and REMSA services on response. Second to that, we might not ever have a regional fire department anytime soon, but we can have a regional EMS first response. And that's what I'm asking for. REMSA is a regional service right now. We can unite what we do for medical care and report back on a regional for medical services from our fire first responders.
Okay, so that felt like an answer with a caveat to me, so I just want to be clear, because you're going to the solution, what the final solution may look like. I believe that we're at a beginning of the process where there's still many possible solutions on the table, and in the beginning of that process, we need that transparency. So regardless of whether we got to a regional fire system, regardless of anything else, are you willing to be transparent with your data? Because I think we need that transparency from everyone to make some of these decisions.
And the answer is yes.
Great, thank you.
Ms. Young.
Thank you, and thank you, Mr. Mayor, and thank you, Mr. Goebbels. Just a couple of things. This to you via our managers, going back to Councilwoman Jardin's point, and that is perhaps you could come to one of our shared services meeting and put together this RFP or contractual buying that we do so we can buy more volume for everybody in the region. It's all the same materials. I know that we restock each other with those. So if you're willing, and our shared services committee is willing, Mr. Mayor, to have that as an agenda item, I think that would move that forward much quicker.
I do think I need to sit down with our fire chiefs and
Okay.
make sure that their idea of an exchange and my idea of the exchange is the same. And we need to sit down as a group and identify those medical items that are going to be exchanged.
Okay, but
that summation can certainly come back, yes.
absolutely, and I think it should go to the shared services elected officials
Sure.
committee so that there is a process and a report and it's public.
Mhm.
Okay, and then finally, and this isn't for you to coordinate or organize, I do believe there's another airport authority fire department that's not here in this room nor being represented when we're talking about all of this. So I would hope that the management staff would make sure that we include them in these in our EMS regional response. So,
Good point.
thank you, Mr. Mayor.
Burke Bigman.
Thank you, Mr. Mayor. I wanted to take this opportunity to thank all of you, Mr. Goebbels and also Sheriff Haley, as well as the fire chiefs and everyone else who have come in here today. This is the first opportunity I've had to see everybody trying to positively work together, and we really need to move forward. There's been a lot of things that happened in the past, but now we need to move forward. We have to stop this infighting and move on. And I know that the Health Board feels the same way, and I'm very pleased to see the response today from everybody who is willing to come forward and work together. And I thank you, Mr. Goebbels, for your time.
Thank you.
Ms. Sheevy.
Thank you, Mr. Mayor. I would definitely second that. Dr. Cohen, just really quickly, this is something that you do all across the country and collect this data? Yes. So I'm curious to find out, if you had to rate us 1 to 10, where would we be?
Dr. Harold Cohen, the record.
Don't try to be too calm. Just go ahead and be honest.
I would, I'll give you bad news and worse news.
Yes.
Bad news, 3. Worst news, that's about where we rate most everybody. It is the biggest system problem EMS now faces in the country, is coming up with patient care from alpha to omega and figuring out what we do. That's why there's no data. If you look at the organizations that are doing well on a national level with data, it's only on a very few things. So don't be too hard on yourself that way.
So how antiquated is our system, 1 to 10?
I would probably still say 3.
3, okay.
About there, but the options are there to go forward, and if you said what is the average across the country, I would tell you it's right about there also. It's the biggest problem we have in EMS, and it's overriding everything to the best EMS systems that we can bring forward.
Okay, thank you very much.
Thank you.
Any other questions? Okay. We want to go back to 7?
Or 6.
Manager's got a report to give? Come on, Mr. Carey, wrap it up for us. There's one thing that we know. Nobody wants to see Mayor Martini and Cashel show up first. That part we understand.
We agree. I want to thank you for your time today. I believe that the managers, the District Health Department, and REMSA are well positioned to take Dr. Cohen's work and work forward to find mutually acceptable negotiated changes that will serve our community well. And we are setting to work on that. And we've been working on it in earnest. And I think that the past has been great to learn from, but the future is what lies ahead of us. And as we move forward, we're trying to craft something which works well today and make it better for the future. So with your concurrence today, our recommendation was to include reports from the EMS working group, which now includes REMSA, as part of your joint meetings as you go forward in your calendared meetings for the year. There are also parts of this which appropriately need to be continually engaged by your EMS dispatch group reporting to the shared services, because that gets into systems that go beyond just fire departments, police departments. It goes into information technology, and it goes at some of the roots of the problem. And the work that Sheriff Haley is already doing with that group is just remarkable. And for Sparks to have an opportunity to upgrade to the same CAD system that Reno and Washoe have been using by way of a grant that Reno will consider is just a wonderful outcome for Sparks. We look forward to that. It's not free. We will have to make a number of changes, but it does get us to where we have a single CAD system, which law enforcement, the district attorney, fire, REMSA, all of the folks in the chain of public safety can truly be transparent and get the right resources at the right time to get the right outcomes. So I don't need a lot of action. Your managers, Dr. Iser and REMSA, are ready to go forward. You've already have in place actions that the Shared Services Committee can continue on, and we'll be back on your next joint meeting agenda for an active report to you, where you'll see some recommendations. The highest areas we're working on are, of course, dispatch, the REMSA franchise agreement, and again, finding a EMS agency that has the authority to provide the seamless oversight that's so critical in patient outcomes. So with that, Mr. Mayor, unless there are any questions, your managers and REMSA will move forward together.
Any questions? Anybody? Yes.
I have a question. In Dr. Cohen's statements, he mentioned early on, well, the geography. We have the geography that we have, and we have to live with it. And then he also mentioned that, you know, we need to have our jurisdictional boundaries start to disappear. And I'm wondering if any of the managers have an idea of, you know, what he means by that and how to address that. Because if I'm taking it the way I think he means it, it maybe goes beyond EMS. It maybe goes to what happened with fire and other service delivery in our region.
Well, I think if Dr. Cohen wants to answer that question first, that would be great.
Thank you, Councilwoman. What I meant by that was that there are fixes to many of these problems in the everyday portion of things. For example, getting dispatch together, having the joint CAD to CAD system, it doesn't really take a trained person to look up at a board and say, okay, here's the emergency. Which piece of equipment do you want to respond to that? And it's really pretty easy to say the closest one. And we have to take the resonant simplicity that will offer to become a natural everyday factor. We also do have to understand that communities are changing. The issues in the Gerlach area, they may not be extremely stable forever. Depends how many volunteers will continue to serve there, and that will be to a point, will be a gap that may have to be fixed, that a joint group will do much better than a fragmented group, should those things occur. We just don't know. We just have to, I believe we just have to be prepared, and that's what I was getting at. And thank you for asking for clarification.
No.
I just have a question with regards to the grant. The grant was a very specific amount of $797, correct? And I guess my question is, the CAD RFPs haven't been collected yet? Because you need direction.
Robert Chisel, Finance Director for the City of Reno. That is correct. What we did was we are upgrading. We got a quote from Tiburon to do the upgrade to the new version of Tiburon for the system, and that is what the cost is. So that is what we applied to the grant for. We also got a sole source justification from the Department of Homeland Security so that we can do the upgrade sole source through Tiburon to do the CAD system. It is far cheaper than if we went out to replace a new system. It would probably be several $1 million.
Okay, so it's kind of an up to grant amount.
It will be 796, because also one of the other items you see on there is a contract with Tiburon for that amount to do the upgrade.
Thank you.
Yes, sir.
Yeah, this is for Mr. Carey. Sean, you identified the 3 priorities, and that's encapsulated the 38 recommendations. I assume at our next meeting that you're going to come back with action items on this and how we're going to accomplish these.
We're hopefully going to complete the prioritization of those 38 actions against those 3 main categories and begin working from what's most important to what's least important and move through all 38 of them in coming months. And that will start with your next meeting. What's most important.
Sounds suspiciously familiar to an organization we did in Sparks. But good, works. And then I just have a comment for Mr. Goebbels. I want to say, since you're taking over, it's a breath of fresh air, and I'm, for one, am letting the past go, and we're going to move forward from this day as a brand new day, and hopefully we can do the rest with the other entities too. And I think your new spirit of cooperation in REMSA, not you particularly, but is refreshing. Thank you.
Thank you, Mr. Mayor. I have a follow-up question. Is one of the things that will be looked at, because of the diversity of our county, how widespread it is and how services are, you know, rural, there's so many rural services and relocated. Will one of the things that will be looked at is repositioning perhaps equipment to a different area, maybe ambulance service, REMSA service, maybe fire service, to relocating them to see if they're in a much more service-oriented area?
Well, I don't think that's precisely in the 38 recommendations, but it does fall into work that is, I think, occurring continuously within each public safety organization. The opportunities inside the franchise agreement, for example, we can eliminate some boundaries which we know of today that are to the REMSA service area that don't lead to the best outcomes. An example is someone in a skiing accident at Mount Rose. It comes from REMSA all the way up Mount Rose, when the North Lake Tahoe Fire District could do that, but there's a defined boundary. And you would have to work with what is a sovereign government in the North Lake Tahoe Fire District to bring in some graying of those lines so that the best resource can get there in the right time to produce the best outcome. And that is fuzzy in my answer, but I think that that underlies the new direction we're going, is to get the best of the scarce resources we have, considering density, considering exposure, and considering the most important characteristics of someone who is in medical distress, and that's time.
Thank you. That is exactly the answer I was looking for.
Any other questions or anything? I think there's pretty much of a consensus that we want staff and everybody to keep going forward with shared services, working with the sheriff. If y'all want us to vote as a whole, I'll call for a vote of the whole to tell you to keep going instead of going individually. Can't do that? Reno can't, but the rest of you can. But I'll take it up at our next meeting. Yes.
So I'll make a motion for the city of Sparks that we direct the managers to continue working on implementing the 38 recommendations as appropriate.
Yes. Second. I would also, oops, I'm sorry. Forgive me.
This is Sparks.
City Council. Ready, and seconded by Councilor Lawson. All in favor, say aye.
Aye.
Opposed? Passed unanimously.
Same motion for Washoe County, Mr. Mayor.
Second.
There's a motion by Commissioner Jung, seconded by Commissioner Hartung. All those in favor say aye.
Aye.
Opposed? The motion carries.
Same motion for the Board of Health.
Second.
I have a motion, second.
Aye.
Okay. Anything else you want to discuss today or questions bring up? Now my favorite motion. Oh, I have to do that. Public comment. Anybody got anything you want to say? Now my favorite motion. Motion to adjourn. All in favor say aye. Those that oppose don't count. This meeting's adjourned.